Good afternoon. Welcome to Grand Rounds today. Please remember to sign the attendance record at the back of the auditorium, and also please turn in your program evaluations. And as I always do, I'll ask you to give us any ideas you might have in regards to future topics or future speakers. Today it is my pleasure to reintroduce Dr. Joe Merchant. Dr. Merchant is board certified in hematology and oncology. He attended medical school at the University of Iowa, did his residency at the University of Virginia, and his hematology oncology fellowship at the University of Wisconsin before returning to Iowa, and he is now a member of the hematology oncology departments at McFarland and MGMC. And he kindly has accepted our invitation today to provide us with a breast cancer update. Please join me in welcoming Dr. Merchant.
Okay, thank you everybody for coming. Steve, thanks for the invitation, and thanks to everybody on the Grand Rounds Committee for the invitation. I bit off more than I could chew in organizing this talk, so some of my objectives that I wrote a month ago, I'm not going to get to today, and I'll have to come back and maybe do another talk. I was asked to do a case-based presentation about breast cancer, and so I initially organized a case for every decade, a woman in every decade starting in the 20s, 30s, 40s, 50s, 60s, and so forth, because there's a lot to talk about, changes that have been, in the last 15 years certainly in breast cancer, but I only got through the 20s and 30s today, so I'm going to just start by talking about breast cancer in general, introduction. I have two cases. We'll just go through them. And what I tried to do is bring up the issues that we face as oncologists, and I see Shane's up there and other medical staff organized around cancer care face in taking care of breast cancer patients. So as an introduction, there are about 250,000 invasive cases and 40,000 deaths estimated in 2017. Did I do that? Oh, okay. This is organized by decade, and just gives you a sense that as we age, breast cancer really is a diagnosis of older women for the most part. A small minority of women in the 50 and under age group are diagnosed with breast cancer, and it's mostly a disease of over age 50 patients, and certainly most of the patients we see are over the age of 50. Okay, so, and this is a slide showing the impact of mammograms on the incidence of invasive breast cancer. You can see mammography became popular in the 1980s and 90s. There was a big increase in the diagnosis of invasive breast cancer, which has remained relatively stable since 1990. The diagnosis by mammography has allowed us, for any radiologists in the room would agree, that we're seeing smaller and smaller breast cancers and fewer larger breast cancers. So here's, you see these are the diagnosis of 1 to 1.9 centimeter breast cancers. That's really dramatically increased since the 1970s and 80s, whereas diagnosis with larger breast cancers has generally gone down. Also with mammography, we see a lot more in situ breast cancer, and some would argue that because we're seeing a lot of in situ breast cancer, we're perhaps over-diagnosing patients. We're giving women a diagnosis they may not need to have, because some would argue in situ cancers have a low chance of developing into malignancy. But in any case, mammography certainly is working as we hoped it would, finding cancer earlier and saving women a diagnosis of a larger breast cancer. The same information showed in a different form. You can see that the percentage of women being found to have a greater than 5 centimeter cancer has gone down from 13% to 7%. The percentage of women being found to have less than 1 centimeter breast cancer is gone from 6% to 18%. So a lot of smaller cancers being found. This is an age-specific probability of developing breast cancer. If you're in your 20s, you have a 1 in 1,500 risk of developing breast cancer, and you have a lifetime risk of 1 in 8. In Iowa, we have 2,300 new cases a year and about 370 women dying of breast cancer. Breast cancer is the #1 cancer diagnosis in women, #2 cause of death in women, behind lung cancer. So this gets us to our first case, to my first case. This is not a mammogram from my actual patient, but this is an actual patient that I met probably in my first couple months in Ames. At the time, she was a 29-year-old woman. She found her own breast cancer in her left breast. It was a palpable lump. She brought it right to our attention, and kind of cutting ahead through the evaluation, we knew because she was so young that we should test her for BRCA1 and 2. And again, this is about 2003. We tested her. At that time, there was only one company that did the testing, and they had a patent on the gene. So they were the only ones who could test. And she was negative for BRCA1 and 2. So we ended up proceeding to do a lumpectomy. She had a 1.9 centimeter node-negative invasive ductal carcinoma that was negative for estrogen receptor, progesterone receptor, and HER2. We gave her chemotherapy with adriamycin and Cytoxan. And this talk, I'm not going to really talk about different chemotherapy regimens. But this was a standard treatment then, and we still use it now. Adriamycin, Cytoxan is very helpful in triple-negative breast cancer. She received radiation, including a boost to her tumor bed. And I'll just tell you, she's still alive. So to cut any sense of drama, she's doing well. I use this slide mainly to talk about breast cancer in a way that I didn't think about it when I joined McFarland Clinic in 2002. Breast cancer, it's really a variety of different diseases, and not all the same thing by any measure. Now we talk about breast cancer really in 4 categories: luminal A, luminal B, HER2 positive or HER2 enriched, and triple negative breast cancer. This patient fit in the triple negative category, which then and now is understood as a higher risk category. Women with triple negative breast cancer have poorer outcomes in general. They account for about 15% of all breast cancers. This is another slide basically showing the same kind of thing. If you look at breast cancers as first dichotomizing them as HER2 negative or HER2 positive. HER2 is treatable with the medication Herceptin, and I'll get into that perhaps in a future talk. Not going to talk about HER2 positive breast cancer today. We look at HER2 negative breast cancer as either ER positive, ER negative, estrogen receptor, ER. Estrogen receptor negative breast cancer is also, or triple negative breast cancer is also called basal-like breast cancer. And we'll talk a little bit more about estrogen receptor positive breast cancer in my second case. Triple negative breast cancer, more common in African American women. It seems to, as opposed to other breast cancers which have a lower risk when women have more children, triple negative breast cancer has a higher risk with increasing number of children. Also has a higher risk with a higher waist to hip ratio. And it's driven by, in many cases, by abnormalities in the BRCA pathway. That's why BRCA1, especially BRCA1 mutant breast cancers, are so commonly associated with triple negative histology. And opposed to estrogen receptor positive breast cancers, which have a lifelong risk of recurrence that continues through 20, 30 years. Estrogen receptor negative breast cancers, highest risk of recurrence is in the first 3 years. So if you get beyond that 3 years, often you do very well. This is just to remind me that triple negative breast cancer and basal-like tumors are not synonymous entirely. There's a lot of overlap, and but then there are some triple negative cancers that aren't basal-like in their histology. This is just a schematic showing triple negative breast cancer behaves differently, metastasizes differently than non-triple negative breast cancer, with a higher rate of lung, liver metastases, and brain metastases, lower rate of bone metastases. This is on the right side shows the recurrence risk with triple negative breast cancer, with a lot of recurrences clustered in the first 5 years. And then after 8 years, if you get to 8 years, your risk of recurring is lower with triple negative breast cancer than with ER positive breast cancer. So once you get to this point, you're better off, I guess, to have the triple negative, because then you can forget about your breast cancer effectively. Whereas women, if you look at in the top here, women with estrogen receptor positive breast cancer, this just keeps going down for 20, and it keeps going down after 20 years. And we will not too uncommonly find patients who present to our clinic with a new pleural effusion or a new back pain, and they have to remember, oh yeah, I had breast cancer when I was 40, or was it when I was 35? I can't remember. And they're 65 or 70. So it's a diagnosis that kind of you never shake. If you feel good when you're diagnosed with breast cancer, well, at least I have an estrogen receptor positive tumor, but the risk of recurrence just goes on and on. Mary Ellen is here, so I just want to acknowledge her work, and Angela and everyone who does genetic counseling for us, because they really keep us up to date in what we can offer our patients. Germline BRCA1 and 2 mutations are certainly the number one thing we worry about in patients who have or who meet a familial risk kind of pattern in their family history. They account for about 5% of all breast cancers and 50% of hereditary breast cancer. They frequently are triple negative, although patients who have low expression of estrogen receptor or progesterone receptor, less than 10%, also have a high risk of being BRCA1 or 2. The risk of, or the frequency of finding BRCA1 and 2 went up dramatically after Angelina Jolie was diagnosed as a BRCA1 carrier, and she underwent a bilateral mastectomy. And at least in studies since then, women have been a lot more willing to come forward and be offered genetic testing. And the number of known genetic BRCA1 and 2 carriers has gone up by 110% since that time. I mentioned that when I came here, the Myriad Corporation had a patent on the BRCA1 and 2 gene. The Supreme Court ruled in 2013 that it's not legal anymore to patent human genome information. So this brought into the market a lot of competitors to Myriad, and this is just, I'm sure, a partial list. But it's also brought to and it's kind of this change in the law has coincided with a change in biotechnology, such that companies are able to do panel testing very efficiently and check for multiple genes instead of just one gene. I know, Mary Ellen, we've worked with Ambry Genetics, and do we do Illumina too? Invitae here. Myriad is still certainly in the business. And you look here at all the genes they can test. Now we send off a blood sample, and we can test for BRCA1 and 2, but also for PALB2, CHEK2, RAD53, and others. And these genes are now being found on a regular basis in our patients. my patient in case 1 that I mentioned, she has moved away from the state, and I would think that she should be retested now with a panel test. Just a few words about PALB2. PALB2 is a gene that we're seeing more and more, and it stands for partner and localizer of BRCA2. It works to prevent cells from accumulating DNA damage. It does, in patients who have a PALB2 mutation, have a up to 35% risk lifetime of breast cancer, which is about equivalent to a BRCA2 mutation. The risk is higher in women who have a family history of breast cancer. So if you have 2 first-degree relatives, you have about almost 60% risk of developing a breast cancer, whereas if you're in a family that hasn't had breast cancer, your risk seems to be lower. Women also have a higher risk of ovarian cancer, and men have a higher risk of breast cancer in PALB2 families. PALB2 is here down in this cartoon. You can see it's a partner of BRCA1 and BRCA2. It's important in helping the cell recover from any DNA interstrand cross-link mistake or double-strand break. Mutations in PALB2 interrupt the same pathways that mutations in BRCA interrupt, and effectively are very similar in how they affect women. CHEK2 is another gene that we're finding now more and more. It's a cell cycle checkpoint regulator, and a single change, single cytosine insertion at position 1100 causes this gene to be effectively inactive, and women have about a 2.7% odds ratio of developing breast cancer. As you can see on the bottom line, the women with CHEK2 have a 20% likelihood of developing breast cancer by age 80 compared to 9%. The risk seems to be, that's ER-positive breast cancer. The risk of developing ER-negative cancer is not as high with CHEK2, and it's just about 1.5 the risk in women without CHEK2. CHEK2 mutation patients typically are European heritage. They are not Asian or African heritage. The 2 countries most heavily represented in CHEK2 kindreds are Finland and the Netherlands. So Finnish or Dutch patients may be considered especially for CHEK2 mutations. CHEK2 mutations affect mostly women who are, if they're going to have a breast cancer, the highest risk is in their 30s to 50s. If you're a CHEK2 family and you're 70, your risk is not that much different from the standard baseline risk for non-CHEK2 families. And this just compares the pattern of of development of breast cancer in PALB2 and CHEK2 families. You can see both typically are over the age of 40 compared to the normal non-mutated families. CHEK2 is considered a moderate risk for breast cancer, and PALB2 is a high risk for breast cancer, similar to BRCA. These are the guidelines for doing genetic testing. I hope they're right, Mary Ellen. Okay, she's always correcting me. So, because they change, but the guidelines are very helpful for women with triple-negative breast cancer before the age of 60 should have genetic testing, and you can see the rest of the guidelines are there. If you're any breast cancer before the age of 50, 2 or more primary breast cancers, if you have ovarian or fallopian tube or primary peritoneal cancer, if you have Ashkenazi Jewish heritage and any BRCA-associated cancer, and then more, opening up the floodgates a little bit more to testing, if you have a first, second, or third degree relative with breast cancer diagnosed before the age of 50, invasive ovarian cancer, breast, prostate, pancreatic cancer, you can see that this, if you have going out to a third degree relative, many patients are going to have 2 relatives with prostate cancer, or 1 with a pancreatic cancer and a breast cancer, and so forth. part of the reason this is important is that as drug development has been driven towards certain subgroups of breast cancer, there are PARP inhibitors, PARP inhibitors, which work especially well in BRCA-mutated cancers, not just breast, but ovarian, prostate, pancreatic cancer. So finding the patients who are BRCA mutated is especially important and there's expectation that PARP inhibitors, which we'll talk about later, I hope, may work as well for PALB2 families. All right, so moving on, next topic with this 29-year-old woman was that she wanted to know whether she could get pregnant after her cancer diagnosis. And she already had 2 children. She ultimately chose not to try pregnancy, but there are important things to consider, and I just put them down here as far as not just for estrogen receptor positive breast cancer, but for all women, young women. One is that certain of our therapies are incompatible with pregnancy. For example, tamoxifen, aromatase inhibitors, trastuzumab. These are treatments that cause birth defects and should be avoided. Prior chemotherapy, that is a woman who's finished chemotherapy, is still, say, 30 years old and wants to have a child, prior chemotherapy does not increase the risk of congenital malformations in the children who are conceived. Prior chemotherapy does reduce fertility depending on the type of chemotherapy administered. Especially the risk seems to go down with the increasing dose of alkylating agents like Cytoxan, one of the drugs we commonly use. Many families wonder, can my wife or can I get pregnant and not compromise my breast cancer survival? There's a fear that getting pregnant will feed the breast cancer or somehow result in a higher risk of breast cancer recurrence or higher risk of death. And that turns out not to be true as best we can tell based on retrospective studies. This large retrospective study was international and looked at women who had finished breast cancer chemotherapy and finished, and then just tried to match women who became pregnant with women who had the same diagnosis, same kind of breast cancer as far as size, nodal status, and so forth. And they were able to show that the women who became pregnant were slightly younger, 31 versus 34. The median time from diagnosis to conception was about 2.5 years. They showed that there's no difference in disease-free or overall survival between those who became pregnant and those who did not become pregnant. There was also no difference in disease-free survival between those who became pregnant less than 2 years after their diagnosis or more than 2 years after their diagnosis. So we often, at least before, would tell women, you really should wait a little while and see how you do. I think in triple-negative breast cancer, I showed you the highest risk of recurrence is in the first 3 years. So I think that's still fairly good advice to say if you can wait 3 years, that's the time, especially in a higher risk patient. But in any case, there doesn't appear to be a difference. And in fact, the studies suggest that there may be a protective effect of getting pregnant in triple-negative breast cancer. You can see here the estrogen receptor negative cohort. The women who did not become pregnant have a worse prognosis than the women who became pregnant. And if you look at the whole population, there's really no difference. If anything, there's a slight suggestion that women who become pregnant do better. Now again, that's retrospective data, and there probably are factors related to the health of the woman that correlate with lower risk of cancer, perhaps better immune system function and so forth. But in any case, I think it's fair to tell women who desire pregnancy that it's safe. There are concerns about women who have estrogen receptor positive breast cancer I mentioned tamoxifen causes birth defects. Estrogen receptor positive women are often recommended to take hormonal therapy for 5 or even 10 years after their diagnosis. So this study, called the POSITIVE study, is in is underway now. It's intending to try to answer the question in estrogen receptor positive women, is it safe to interrupt your hormonal therapy? This is sort of the schema of the study. Patients had to be between 18 and 42. They have to have completed between 18 months and 30 months of their hormonal therapy. So they want to have that much under their belt. The idea is that you stop the treatment, wait 3 months, get pregnant, be off your hormonal therapy for up to 20 months, I think it's up to 2 years, and then restart your hormonal therapy. And they're looking at overall survival, disease-free survival, and so forth. And it's going to be an interesting study to get the results from. Okay, so my young patient, just to summarize, she was 29. She received chemotherapy. She decided not to get pregnant. We did a genetic testing, 2003 version. We probably need to get her back, but she lives in Arizona. So anyway, she's not going to get that for now. But that nowadays she would get a panel test, and I think she may have, if she had a mutation, a PALB2 mutation or a CHEK2 mutation, she may have undergone a bilateral mastectomy. So anyway, let's go on to case 2. This is a different patient, very similar cancer. She presented to her primary doctor with a palpable mass. It was on surgery, an estrogen receptor positive, progesterone receptor positive, HER2 negative breast cancer. So a very different cancer, same size as the first one, but estrogen receptor was found on the surface of the cancer cells. This woman did not have lymph nodes involved again, so this is a stage 1 cancer, just like the first patient. But because she has estrogen receptor expression on her cancer, this raises a whole host of different issues as far as our care. The first one is, again, something that wasn't available when I came to Ames. The first papers for the Oncotype score came out in 2004 or 2006. But this patient underwent what we call Oncotype testing after her diagnosis, something that we only do in estrogen receptor positive breast cancer. And she was found to have what we call a high risk. Her score was 37. And I know that doesn't mean a lot to most of you, but it's a high risk score. Because of her high risk score, we recommended that she get chemotherapy, radiation, which she would have gotten anyway, and hormonal therapy, which she would have gotten anyway. So I want to just talk about Oncotype score and a few other things. So these are, the Oncotype score is a way of kind of interrogating the genetics of the cancer, trying to find out if this is a high-risk cancer or is this a low-risk cancer. The Oncotype score looks at 21 genes. 16 of them relate to the cancer, and 5 of them are sort of comparator genes that they're just comparing the activity of the cancer proliferation genes to. What they did initially was they took tumor blocks from women who participated in 2 historic breast cancer trials, NSABP B14 and B20. These trials were performed in the 1980s and early 1990s. And the investigators in those trials had the foresight to save paraffin-fixed tumor blocks in the women who participated in the trials. So the Oncotype investigators got those blocks, performed their test on those tumor blocks, and then compared their results to the outcome of those women, which was known by the NSABP investigators. So they were able to effectively check their results against what actually happened to women who participated in these trials. These are the 2 trials. I'm not sure how well that shows, but NSABP B14 compared placebo to tamoxifen, and B20 compared basically tamoxifen to chemotherapy plus tamoxifen. These were the results in this trial. This is one of the first trials looking at how did the Oncotype score perform in hormonally treated versus untreated patients. And you're able to see that in this trial, 51% had low-risk Oncotype score, and 27% had a high-risk score. And the rate of distant recurrence was quite a bit higher in women with the high-risk score, with a 30% distant recurrence risk compared to a 6%. So they knew they were onto something with their Oncotype score. And this is looking at, again, low risk. How did the low risk patients survive? Very high survival, very low risk of dying of breast cancer. Clearly, the high risk patients have a different kind of disease and a different kind of prognosis. And the argument has been made since then that those patients should really be treated differently. If you look again, the Oncotype recurrence score is a continuous score between 0 and 100. And the low-risk group has been arbitrarily or somewhat arbitrarily defined as below 18, high-risk group as above 30. The intermediate group is kind of a vexing group for us because we don't know exactly what to do with these women. We know they're at higher risk, but it's not clear that they benefit from chemotherapy. The chemotherapy trial, NSABP-B20, showed, again, similar proportion of patients with low, intermediate, and high risk. What this trial taught us was that the benefit of chemotherapy accrues almost exclusively to women who are in the high-risk score. That is, women who have low and intermediate risk breast cancer, by Oncotype scoring at least, don't appear to derive any benefit, or very little benefit, perhaps is the better way to put it, from chemotherapy. This is, again, just sort of a different schematic of the same information. These are the women who have high-risk breast cancer. If you receive chemo, you do way better than if you don't receive chemo. Whereas the women who have intermediate risk or low-risk breast cancer seem to do just as well with tamoxifen alone as with chemo plus tamoxifen. So this shows this is kind of a schema that we show a lot of our patients who get the Oncotype score. We're able to say to them, you know, your score is 37, so that puts you right here. There's a big difference for you to get chemo compared to no chemo. And those women, when they see the information presented in this way, can immediately grasp that they have a lot to gain from chemo, whereas women who have an Oncotype score of 10 don't have a lot to gain. This is just a typical distribution, what we see in our clinic every day, women who have an Oncotype score. It's pretty rare to see a score up here in the 70 range. It's much more common to see low-risk patients or intermediate-risk patients. The TransATTACK trial, the ATTACK trial compared tamoxifen, our old standard, to an aromatase inhibitor called anastrozole. The ATTACK trial was able to show that, again, the recurrence score, what they did is look back at the blocks, analyze the blocks, and they're able to show that patients who had anastrozole had a benefit compared to tamoxifen, and the benefit was similar across risk groups for recurrence score. They, this shows the survival according to low, intermediate, and high risk, proportion of distant recurrence-free survival. And this, I believe, is node positive on the bottom, node negative on the top. And I would just pause to show you in a node negative woman with a low recurrence score, your 9-year freedom from disease-free survival is 96%. The same woman who has a single lymph node and positive and a high recurrence score is a 51%, just a flip of a coin chance of surviving without recurrence to 9 years. So there's clearly a great deal of power in the molecular testing, and we were able to sort patients with this kind of testing and decide who gets chemo. Increasingly, we're wondering and testing the idea that Oncotype score is also important for node-positive breast cancer. Women who have 1 to 3 nodes positive or even 4 nodes positive, you can sort recurrence risk by their Oncotype score. And similarly, many would argue that the benefit of chemotherapy, even with multiple positive nodes, primarily goes to women who have a high recurrence score. So we can perhaps spare women with 5, 6 positive nodes chemotherapy, some would argue, with a low recurrence score. The TAILOR-RX study looked at women with trying to get a more prospective idea of what happens to women who have low, intermediate, and high-risk scores. Women who had a low-risk score, in this study less than 11, were given endocrine therapy alone. That's just hormonal therapy by itself. High-risk scores, more than 25, got chemotherapy and endocrine therapy. The intermediate risk scores were randomly assigned to chemo plus hormonal therapy or chemotherapy by itself. This is a sort of a prospective validation of the Oncotype score. And they are able to show that if you have a low-risk score, a low-risk Oncotype score, you have a very low risk of recurring with your breast cancer at a distant metastasis of less than 1%, any recurrence of less than 2%. And the recurrence events were not affected by age at diagnosis or by histologic grade. It's important to keep in mind that this study only has been published up to about a 5 years of follow-up, 68 months. And so the majority, or about half, of recurrences for ER-positive breast cancer are still not happened yet. So there may be further interpretations of the TAILOR-RX study. But this is why the AJCC has changed the staging system for breast cancer. The 8th edition, which just will take effect in January of 2018, incorporates molecular testing for the first time in our staging of breast cancer. And the way it does so primarily is by downstaging women who have a low Oncotype score. So you can have now, if you have up to a 5-centimeter breast cancer, which would normally be automatically a stage 2 breast cancer, if you have a low Oncotype score that is less than 11, or if you have a low-risk molecular study of a different type, you are now counted as the same, considered to have stage 1 breast cancer. So there's this new concept of the prognostic stage and the anatomic stage. And the prognostic stage is the new part that we'll be incorporating into our staging of breast cancer. So again, the recurrence score will allow a tumor that is up to 5 centimeters to be placed in this T1A, T1B prognostic scoring group. And the same, we can also use other molecular scoring systems like EndoPredict, PAM50, MammaPrint to accomplish the same thing. I wanted to, before going much farther, talk about MammaPrint. The MammaPrint is a kind of, I guess you would say, a competitor to the Oncotype score. It was initially developed in Europe and required frozen tissue for it to be interpreted for many years. So it didn't have much influence in the United States. But it's recently been, they've made it available in the, with paraffin-fixed tissue slides so that it can be run on any woman with breast cancer in the United States. The MammaPrint study, or the 70 gene study, this looks at 70 genes as opposed to 21, and it gives a score that ranges between minus 1.0 and plus 1.0, or trying to give either a yes/no answer to physicians. So instead of the Oncotype score where you're given an intermediate category, an intermediate risk, which we're scratching our head about, the 70 gene assay just gives us low or high risk. So there has been a large prospective study like the TAILOR-RX study for the Oncotype score. The version of that for the 70 gene assay is called the MINDAC trial. And the MINDAC trial tried to look at the prospectively what contribution could be made by the 70 gene assay to the management of women with breast cancer. This is the schema of the trial, and as opposed to the TAILOR-RX trial, this looked at node negative and 1 to 3 positive nodes. TAILOR-RX was primarily node negative, but this is the women who had a high pathologic risk and a high mammoprint risk all got chemo. The women who had a high mammoprint risk, a low mammoprint risk and low clinical pathologic risk all got endocrine therapy. And then the randomization part of the trial was for women who are in the middle. So in this trial, they used an online program called Adjuvant Online, which is from the Mayo Clinic, that allows you to categorize women's risk of recurrence based on factors related to their age, size of the tumor, number of positive nodes, and so forth, estrogen receptor positive or negative, HER2 positive. So they use the Adjuvant Online data to say that you're at clinical pathologic high or low risk, and then they use the 70 gene assay to stratify risk. And there were patients who had a high clinical risk by Adjuvant Online, but low 70 gene risk and vice versa. And those patients were randomly assigned to chemo or chemo and hormonal therapy. And they are able to show that women who have, clearly the highest risk are the women who have the high genomic risk. Low genomic risk have a much lower risk of recurrence. And then there are groups who have a low genomic risk but high clinical risk. They seem to be somewhere in the middle. The PROMISE trial is a trial that the PROMISE trial is a trial that is trying to or that did try to help physicians who are on the fence about intermediate risk Oncotype scores. What they did in the PROMISE trial is they took women who have 18 to 30 Oncotype score and they ran the 70 gene assay on those, trying to find out, are those women high or low risk, and then what they did was present that information to physicians and measure whether physicians changed their recommendations. They didn't look prospectively to see whether this saves lives, but they are able to show that, they are able to show that about half of the women who have an intermediate risk score on the Oncotype test, half have a low risk and half have a high risk on the 70 gene assay. So this at least raises the possibility for doctors like me and my partners, if we want, to ask to have an Oncotype score, and then for intermediate risk patients, also do the mammoprint study. They showed in this PROMISE trial that a lot of physicians changed their recommendations for women who have intermediate risk Oncotype score. I think you can argue that's a lot of money spent. I don't know, Jamie, have you priced out the 70 gene assay yet? It's probably $5,000 probably. That's what the Oncotype score is roughly. So you're looking at spending $10,000 just for prognostic information. I can't imagine doing it, but at least there are people who are trying to really drive the molecular identification of who needs chemotherapy to the nth degree. This is just from the PROMISE trial. It shows that if you look at women who have the intermediate risk Oncotype score, that is between 18 and 30, what is the distribution? If you look at the x-axis, the mammoprint study, and you can see about half have above and half have below, high risk versus low risk cancer. So I think this may argue for some physicians in the future to skip the Oncotype study and just go to the 70 gene assay to try to help make your decision making easier, so that you just either get a yes or a no, need chemo, don't need chemo. And both would be working within the new staging system. Just a few minutes on optimal hormonal therapy. So this patient of mine was found to have high risk by Oncotype Score. She had a 1.9 centimeter breast cancer. We gave her chemotherapy. So then the question is what to do next. She got radiation therapy also. So what chemotherapy do we give? What hormonal therapy, do we give? The long tried and true treatment for a premenopausal woman has been tamoxifen, which works equally well in pre- and postmenopausal women. Tamoxifen has been shown to reduce the risk of 15% reduction of, 15-year risk reduction of 39% in recurrence and 30% in mortality. So it's a clear benefit. Because 21% of breast cancers are diagnosed in women below the age of 50, there's a lot of women who need advice on what the best hormonal therapy is. The hormone receptor-positive subtype is obviously the most common. In postmenopausal women, we have the option of using an aromatase inhibitor. There are 3 aromatase inhibitors on the market: anastrozole, letrozole, exemestane. These 3 all appear to be equivalent to one another, and they all have about a 15 to 20% advantage, at least as judged by disease-free survival compared to tamoxifen. The SOFT and TEXT trial looked at whether women who have breast cancer, who are premenopausal, should consider undergoing ovarian suppression by a shot, similar to how men are put into low testosterone state with a Lupron shot. And these women then are able to get the advantage of an aromatase inhibitor. So the question of the SOFT and TEXT trial is there an advantage to women of having their ovaries shut down and going on an aromatase inhibitor compared to maintaining ovarian function normal and taking tamoxifen? This is kind of shows the SOFT and TEXT trial. The 2 trials are kind of related. The TEXT trial compared ovarian suppression plus an aromatase inhibitor to ovarian suppression plus tamoxifen. The SOFT trial looked at the same 2 groups plus a group that was assigned to just tamoxifen. And you can see each group had about 1,000 women. And we're starting to get published information from these studies. They were able to show no difference in overall survival between women who had ovarian suppression and tamoxifen and ovarian suppression and exemestane at 68 months follow-up. But women who had exemestane plus ovarian function suppression had an advantage in terms of recurrence risk compared to tamoxifen, especially in women who are at high risk, women who had node positive or women who are eligible for chemotherapy. So this raises, you can see in this disease-free survival, there seems to be a benefit for exemestane plus ovarian suppression compared to tamoxifen plus ovarian suppression. Now, we don't yet have the published information of where does tamoxifen alone go in this, but overall survival is equivalent. There do seem to be subgroups in the TEXT and SOFT trial who benefit. So in my patient who's 37, we have a difficult decision to be made about whether she's high enough risk to have her ovaries shut down. This is a big decision. Obviously, impacts her quality of life greatly. So the SOFT and TEXT information is something that we're struggling through with our young women and trying to present the information and help them make educated decisions. There are women who are certainly high enough risk for recurrence that we are offering ovarian ablation, and at least for the duration of their 5 years of aromatase inhibitor therapy, then you can stop doing the Lupron shots and allow them to resume ovarian function if it comes back. So that's just a 2-patient study through some of the issues of breast cancer care, and I'd be happy to answer any questions if there are any, I'll try to come back and do another update of older issues related to older women and some of the newer drugs that we're using. Thank you.
Joe, I was riding home in my car the other day and I heard an advertisement for, I assume, BRCA testing, that people don't have to go through their physician. They were actually, I think there was a $100 discount for Christmas. So
Yeah.
you can give this to your friend. And it's concerns about that for people just themselves randomly sending their blood off to get BRCA testing and not knowing how to interpret the results if it comes back positive, and just what your thoughts were.
Yeah, I agree. I mean, I think that partly Mary Ellen had to leave, but we do take a lot of time to have a genetic counselor meet with women, and there's a good reason for that, because women, or not just women, men too, can overreact or perhaps overcompensate for changes in their or findings that they have a genetic risk. So I think there's a potential for harm there, but it is nice to see the costs coming down, and patients are able to get some limited information from these lower cost tests. We always face a difficult time getting the test paid for, especially in Medicaid or underinsured patients. So I'm glad that the cost is coming down. I agree. Interpreting genetic information is tricky, even with a genetic counselor. And you could have women who perhaps get the test information, don't tell their doctor. The doctor doesn't know they have a risk. I mean, I could imagine it could be handled all sorts of ways that are unfortunate. So I agree. I think
online, and there is some component of counseling, but still direct consumer.
Yeah. The other problem which you ran into is the variance of unknown significance. When we do these tests, genetic tests, we're learning. We have a variant of unknown significance in the BRCA or PALB2 or CHEK2. These are cases where the patient is told, your gene is not perfect. It has some abnormality. We don't know whether it causes risk or not. So variants of unknown significance are causing a lot of, anxiety for some of our patients. And some women choose to have bilateral mastectomies with a variant of unknown significance. May not be necessary. Maybe it appears that interpreting variants of unknown significance is really best to do in the context of the family history. So if you have a woman who has a variant with a very worrisome family history, probably best to treat that as a real, pathologic gene, especially in a younger woman. But you're right, it's a moving target, and we're going to know a lot more 10 or 20 years from now. So, any other questions? Yeah.
Especially with the kind of the medical legal risks that there might be if you don't and then she recurs, so many years later. So how do you handle that? Or do you usually find that women are relieved and then they just walk away being, maybe they're, with their hormonal therapy and being happy with the outcome of the Oncotype DXing?
Well, I think we try as much as we can to use other factors like the Ki-67. If the Ki-67 is high, this is a proliferation marker, and you have an intermediate risk, you may advise more to chemotherapy. Whereas if you have a low Ki-67 intermediate risk, you could perhaps be okay with no chemo. If you have other high-risk features, you maybe, I think we often give chemo to intermediate risk patients, not knowing for sure and hoping to see the Taylor-X study in that patient population show a benefit. But it's been, the follow-up is now more than, and they haven't been able to show a benefit yet for chemotherapy in that patient population in the intermediate risk. It's probably, if it's going to be there, it's going to be a few more years before we'll know it. Most of the benefit to chemo is in the first 5 years of after diagnosis. So the fact that they haven't shown a benefit and the follow-up, the median follow-up of the Taylor-X study is more than 5 years, it may show in the end that it's, if you look at that group, that subgroup as a whole, that you're not going to see a benefit for chemo. There may be subgroups, though, where they say, you know, a woman with a certain above 25 or some, I don't know what they'll say. But I think for many women, you present the information, you show them the data, you say, you know, what do you want to do? They'll say, if it even helps me 1%, you know, I want to do the chemo. And that's understandable, you know, in a young person. So I think we're often giving chemo when we're not sure. And that may be a place where we get tired of that uncertainty and go with the mammogram study. Yeah.
Hey, Joe, is there any data to suggest that women who receive alkylating agents for adjuvant chemotherapy have an increased risk of lymphoma or leukemia down the line?
I think they have a higher, the alkylating agents, not so much, but the adriamycin with it, yeah, for sure. Leukemia down the road. Secondary leukemias for sure. Alkylating agents can cause sterility as one of its main effects, but I don't believe it's as genotoxic as the adriamycin. So. Okay, thanks. Thanks for coming.